And I remember our team reached out to Vern in the setting of COVID-19, and we said, is this the right time for us to do this? Should we wait? And you know, Vern in her true self said, look, this is our time to continue to show hope, continue to show what we're doing, and move through this time so we
Sorry, Dhruv, I don't mean to interrupt, but there's some messages saying that this isn't live on Facebook anymore.
This is not being broadcasted to Facebook.
Okay. I'm happy to, I'll hold Vern until we know we're live.
Yeah, there's some members that are in the chat just relaying the message that this is not currently being streamed on Facebook. So I actually went to Facebook to try to find it, and I can't.
Can't hear you.
I've begun recording this where you started with my slide, and I'll just post the recording. I don't want to delay us any further because we're already at half the hour, and I want to get to all the panelists and not have you on so late. So if Pernell, if you're on, would you please send a note or a post to the group that we're going to go ahead and record and post the video later.
I will.
For the group. Thank you. Let's just keep going, Dr. Singhal.
So, but this is an important message, so I'm going to repeat it, okay? These are unprecedented times here in the world and the country. And Vern, you continue to bring hope to the lymphedema community. And again, it's an honor for us to be here. This is a snapshot of Vern's lecture in 2019, this Century of Hope. And you can actually go online to harvardlymphaticsurgery.org, which is our symposium site, watch Vern's lecture or any of the other lectures over the last 3 years. We've had over 27,000 views over 3 years. And this is free education for anybody and everyone that has come out from our symposium. And we were obviously heavily supported and thankful to learn for that. And I know SCT was very important in your trip as well, Vern. So again, thank you for extending this opportunity and stage. And none of us have any disclosures. And really tonight, I really just want to talk about our team approach and what we do to deliver high-level lymphatic care. And I just want to hit on some main points about the Lymphatic Center. It was established in 2016. It is patient-oriented. This is very important. There is no cure for lymphedema. And so if there is no cure for lymphedema in 2020, then when a patient walks into our clinic, we must really spend time understanding what the patient's goals are and make sure before we do anything that we can deliver to their goals. We are multidisciplinary. And I hope you just see that just by the very fact of who is on this line tonight, and you're going to be hearing from many of them through this talk. We have seen over 900 new patients for the evaluation of lymphedema or lymphatic diseases in the last 3.5 years. And what's critical to our success thus far and for what we continue to hope to do moving forward is we have amazing institutional support from Pete Healy, the president, vice president, chairs, chiefs of our divisions. We have been supported to deliver this service to the community of patients who have lymphatic disorders and including lymphedema. Now, Vern, this is really an honor for us. We have chosen today to be the first time in your Facebook Live event to share our mission statement. This is a mission statement. Every word this is something we spend weeks on as a team to put in and etch in stone. And we have essentially voted on every word and the sequence. So I'm going to read this to you. This represents our team and what we stand for and what we want to deliver. This is our mission statement. The Lymphatic Center at the Beth Israel Deaconess Medical Center provides compassionate care and advocacy for individuals with lymphatic disorders while uniting healthcare providers and researchers from all disciplines to advance our knowledge of lymphatic disease and therapy. So again, thank you for letting us share that in this forum.
Thank you. That's actually perfect. That's perfect.
Okay, so let's get into this. We're going to talk about our center, and as I think you'll see as we go through this, the key we believe to any center is the team. And you got to have a team. You can't have a bunch of all-stars on the team. You got to have all-stars that work together, learn from each other, push each other, and always have only one thing as the bottom line, and that's the patient. So our lymphedema program has 3 basic pillars: lymphatic surgery for the front lines. It's lymphatic surgery, lymphatic therapy, and lymphatic medicine. We consider that our clinical triad. Any patient that walks into our center will be first evaluated in one of these 3 clinics. As I've already mentioned, we are heavily supported by radiology, and that comes including body imaging, nuclear medicine, as well as interventional radiology. If you put it all together, if I may, all of these clinics make up our all-star team. And obviously we are heavily supported by other services throughout the hospital. And if you want to see what we look like, I can't put everyone up here, but these are representatives from each of the main disciplines. From lymphatic surgery, you see me, next to me is Tilly, our lead lymphatic nurse practitioner, Sarah, our lead lymphatic nurse. In lymphatic therapy, this is led by Kathy Shalou, Colleen. Tegan now runs and leads our inpatient therapy team as our inpatient census has increased. Dr. Brett Carroll is taking the helm here in lymphatic medicine. In body imaging, we have Dr. Leo Tsai, also again supported by Dr. Jeff Weinstein and his interventional radiology team, as well as Dr. Donahoe bringing his expertise in nuclear medicine. So this is all of us, a little outdated photo. I know we need a more recent one at about 7 o'clock in the morning being told to smile. This is the key, okay? This is the key. This is the blueprint. This is the treasure map. This is how we work. A patient calls our center. We quickly decide, does the patient have lymphedema, which is the more traditional referral to us, or are we trying to prevent lymphedema? This is a patient who has an active cancer usually, and they have disease in lymph nodes, and a surgeon has made a decision lymph nodes need to be removed, and that alone is the single biggest risk factor for getting lymphedema. So those patients are sent to us for potentially some prophylactic or risk-reducing procedures. If you are coming in this category right here, this is an active cancer patient usually, so they move very quickly through. Right here, you see our clinical triad. So that patient will come into the surgery clinic, Kathy's lymphedema treatment clinic, will coordinate with the surgeon, proceed to the operating room. But a patient who has chronic lymphedema is much more complicated. And so when they come in, they actually see Dr. Carroll and his team in the lymphatic medicine clinic, Ms. Shalou and her team in the treatment clinic. They go through a series of questions, we'll meet as a team, and only then, if we think it's pertinent, will they come to lymphatic surgery. If they don't have lymphedema, we will figure out what they do have and appropriately treat them. If their therapy isn't maximized, Ms. Shalou will work with local therapists close to the patient to maximize the therapy. And if they're not an appropriate surgical candidate, Dr. Carroll and his colleagues in medicine will figure out what the right medical treatment might be. So we're gonna go ahead and talk about each clinic. That is really the bulk of this talk. And we're gonna start off with the lymphedema treatment clinic, which is led again by Miss Kathy Shalou. And Kathy, I'll click for you, and I'll let you take it from here.
Okay. So as Dr. Singhal mentioned, we have several different roles. Patients who don't have lymphedema yet, we see them before their surgery and at intervals after their surgery, 6 weeks, 3 months, 6 months, 9 months, 12 months, every 3 months for the first 2 years after their surgery, and then every 6 months for another 2 years, because what we want to do is monitor them to make sure we can identify if they start to develop any lymphedema, we start treatment right away. So early identification and early treatment. We treat patients who have lymphedema. We see patients pre and post-operatively if they go on to have lymphatic surgery. And we follow patients who don't need surgery long-term to make sure that we monitor their disease status and keep them under the best control possible. And then also communicating with the rest of the team as we go along. So measurements that we take using tape measurements, calculating volume with perometer and bioimpedance to measure body fluid, percentage of body fat, percentage of skeletal muscle mass, all of these to help identify where somebody is in the disease progress and make sure that they stay under the best control. We also use patient completed outcome measures like the LymphQOL form and also a patient-specific functional score, so we get the patient's perspective on how well they're doing. The gold standard still is CDT, or complete decongestive treatment, and has components of manual lymphatic drainage, compression bandaging, that's in the more intensive phase to reduce the size of a limb. It also includes exercise and educational skincare and risk reduction. These are also the same pillars that some patients are going to have to use for self-management in long term. One of the pillars of control is compression. That's the mainstay, really. And one of the questions I always ask patients, how many hours a day are you in compression? Because it's not always about the type of compression you're in, but how many hours a day and how many hours a week. And that's one of the metrics that we measure long term. Sometimes you can see over 35% of the patients that we see are in compression more than 16 hours a day. And actually, most of the time it's day and night. So it's basically 24 hours a day. But there's a large number of patients that don't wear compression at all. And so one of the questions that I ask is, why not? It might be that their compression is not working. They gave up on it, which we don't want to see. We want to keep them under good control. And so working with a fitter to find out why they're not wearing compression. If it's not helping, it's not working, maybe there's another type of compression that we can use. It might be that we have to change the number of hours they're using compression or change the type of compression they're using, but not just give up on it. We really want to investigate to find out why it is that it's not working. But basically coming back to maximizing control, that's the main function. We look at, is there pitting? Meaning when you push your finger into the skin of your leg or your arm, does it leave an indentation? And how much does that swelling increase during the day? Those two will tell us whether or not we need to improve the compression. And it might be increasing the hours in compression, it might be increasing the class of compression, or a different type of garment. Or it might be that the swelling is localized to one particular area, in which case we might change from an off-the-shelf or ready-to-wear garment to a more customized garment, or even layer 2 layers of garments over an area that has less control. But really working with the fitter and the lymphedema therapist to find out why it is that the compression is not working if it isn't, or even if it is working, is there some way we can maximize the control of the edema with better compression? And then pre and post surgery, our role is really pretty much the same before going into any of the procedures, whether they're the physiological procedures or the debulking, which Dr. Singhal may speak about a little bit later. Making sure patients have maximized their control of their edema before they go into surgery, so they go in the best shape possible. And then after surgery, during the healing phase, starting back with more CDT treatment, and then long-term, over the months as they heal after surgery, making sure they get the best outcome possible by maximizing the control of their edema. So we measure patients at intervals. We use those objective measures to try to determine whether or not somebody has stabilized. Is their edema stable? If it continues to decrease, we're going to continue to change their self-management program at home. And once we determine that it is under good control, is it well managed, then we give feedback to the rest of the lymphatic team. So that's how we fit into the team. We may give feedback to the surgical team or back to the lymphatic medicine program to to determine what the next steps are for patients.
Thanks, Kathy. And that is, we consider the lymphatic treatment clinic our workhorse. As you can see, every arrow leads to the lymphedema treatment clinic. So they really are our engine for the entire program. I'd like to move on now and switch to our next clinic. Critical really is the clinic that rounds out the program, and that is our lymphatic medicine clinic, again led by Dr. Brett Carroll, Director of Vascular Medicine and Lymphatic Medicine at Beth Israel. Brett, take it away.
Thanks, Dhruv. I feel like the main goal of our clinic is a couple-fold. Make sure that the etiology or the cause of your lymph swelling and symptoms is due to lymphedema. And if it's not, as Dhruv had mentioned, really taking care of that problem and making sure that's thoroughly evaluated. And then secondary to that, and working very closely with Kathy and her team in physical therapy, is to making sure you're really optimized from a conservative standpoint. So just a few slides on the underlying causes of lymph swelling with a real focus on lymphedema, obviously. The most common cause in the US and the world is secondary lymphedema. So an injury to the lymphatic vasculature. It accounts for 99% of all lymphedema cases. And although not very well appreciated necessarily in the medical community, it's quite common. 1 in 1,000 individuals can experience lymphedema. The mean age in the 50s when it's related to secondary lymphedema. The most common cause in the world of secondary lymphedema is a parasite called filariasis that invades into the lymphatic system and can cause significant lymphatic dysfunction. In the Western world and developed world, it's related to cancer, and not necessarily cancer itself, but the treatment of cancer. So removal of lymph nodes or radiation therapy, most frequently for breast cancer, causing upper extremity lymphedema. Go to the next slide, Dhruv. So in terms of what are the causes of cancer-related lymphedema, it can be multifold. So it can be the direct trauma to the lymphatics from lymphadenectomy, which is the medical term for removal of lymph nodes. It can be due to radiation, chemotherapy, lymphatic compression due to the tumor itself, or infiltration of the cancer into the lymphatic vessels directly. So although we commonly think of breast cancer, it is most frequent just because of its prevalence in the community. And when you remove lymph nodes and do radiation directly to the upper chest wall in the axilla area, you're at high risk to develop lymphedema, but it's not uncommon with other cancers, including melanoma, urinary and gynecologic cancers, and sarcomas, which are cancers of the bone which can occur in any limb. And you can see up to a quarter of patients or a third can experience lymphedema. And it doesn't need to happen right after surgery. It is most common soon after the insult with radiation or surgery, but it can occur several decades later after a secondary insult. So we have to keep in the back of our minds, even going out a few decades. In terms of breast cancer-related lymphedema, prevalence up to 30% of patients that have axillary lymph node dissection and radiation can develop lymphedema. We won't belabor the points in terms of the risk factors, but more lymph nodes removed, concomitant radiation, certain chemotherapy, increased weight can all increase your risk of developing lymphedema. So when we see a patient in clinic, we make an effort to say, although you've been diagnosed with lymphedema in the past, you're coming to our clinic with edema, with swelling of the limb, and it's our job to really confirm that it is lymphedema that's causing it. Most frequently it is lymphedema. We want to make sure we're not missing anything else that could be contributing to that as well. And there's a long list of potential causes of limb swelling in both the lower extremity and the upper extremity. Again, we won't go through this list in too much detail. You can move on, Dhruv, to the flow diagrams. So when you come in with lower extremity swelling, we really have to think, okay, is it one leg or is it two legs? If it's two legs, we have to think, is there a potentially more systemic problem? Do you have heart failure, liver failure, kidney failure, low thyroid levels? Is obesity driving a lot of this? Do you have a particular medication or some other exposure that could be driving it? Those are less common, but something we need to consider. So we tend to get a broad spectrum of blood tests And if those are normal, we look, okay, what are your other causes, more of a local process that could be causing it? Do you have a history of a prior blood clot in the legs, prior trauma to the legs, any recurrent infections that may be driving the issues with lymphatic flow or otherwise? And similarly, if it's one leg, then we really focus, is it a vein or lymphatic issue? We do a very thorough physical exam. I think the physical exam in medicine has gone by the wayside for a lot of what we do, but for limb swelling, and especially realized over the last couple of months, trying to do lymphedema exams by phone is suboptimal, to say the least. So very important to get a good thorough exam to make sure there's a lot of clues that we can gain from that of why you may have limb swelling. And then we weigh heavily, which you'll hear more about on our radiologists, to help confirm our suspicions based on the history and physical exam, which can really nail down the diagnosis of either lymphedema or another potential contributor. And the same goes for upper extremity. The differential diagnosis, meaning the list of potential causes for arm swelling, is lower than for that of leg swelling, but it's still something to think about. We can see issues with the veins in patients that have had prior ports or radiation. Blood clots are not unheard of in the upper extremities. So again, a similar approach when we think of the arm. And this is just to note that this is a French group, and our numbers are not exactly this, but similar in that a lot of patients come to a lymphedema clinic diagnosed with likely lymphedema, and a lot leave the clinic without the diagnosis of lymphedema, meaning either we're not sure and we need to objectively define that with imaging, or it's clear that there's just some other cause, and we need to more thoroughly evaluate that. And that's really our job in the lymphatic medicine clinic.
Great, thanks, Brett. And as I said earlier, this is a critical clinic for us. I remember when I share this story because it just speaks to how I view this clinic. When Brett first called me to say, hey, he took the job at Beth Israel, I was literally outside and jumped up and down because I knew this was critical to provide the best care that we could provide for patients with lymphatic disease. So, you know, we have hit upon the clinical triad, or the two parts of the clinical triad. I'm going to end with surgery later, but what I want to show you and then really show you is, as beautiful as this referral scheme may be, and this is how we work, nothing in life actually works that cleanly. And this is actually what happens. So what actually happens is every member of our team, the clinical triad, the all-star team, the radiologists are there, our researchers are there. We get together every Friday at 7 a.m., including even during COVID-19, and we do it virtually. We're not sitting this close together, but we truly, Sarah generates a note from this clinic. It goes into the medical record. Every person who was present is listed on that note, and we make decisions as a team, and we truly do. If Kathy turns to me and says, this patient's not maximized, shouldn't go to surgery, we don't go. But if Carol says, you know what, I think we need further imaging, or I want to rule out X, Y, or Z disease, they don't go. So we truly work as a team, and as Kevin said, or Dr. Donahoe said recently, that's probably the biggest strength we bring to all of this. So
I cannot agree. I mean, if I can interject here, that's one of the things that I think is, you know, the stellar, I mean, the exceptional about your facility is that you have this team effort and you do discuss these cases as a team. And, you know, from a patient perspective, a lot of times when I've been in that situation myself, you know, years ago when I was trying to get treatment again, you know, I've been to the quack. I've been to someone who was not up to par, and it's, as a patient, you tend to take their word for it, you know, and having this whole holistic of, well, that holistic, but a bigger picture point of view, I think is just stellar. I cannot say enough about it. I think it's great.
Well, Vern, I think, you know, thank you for saying that. I think it gives the patient strength, but it gives somebody else a lot of strength too. And that's the clinician. Because sometimes we are doing things that are on the edge safely, but like a lymph node transplant, where, you know, some physicians may say that doesn't work, but other physicians, those of us who do it, believe in it. But we work as a team to say, is this the right thing for the patient based on what we know and our experience? And so most importantly, I agree, it empowers the patient, but and I would argue, it also empowers the team that's trying to provide the best care that we know how. So thanks for saying
Agreed.
that. So, you know, our radiologists are known for sitting in dark rooms and reading screens and staying out of the limelight. So you can see Dr. Sai here trying to hide away in the corner of this picture. But I'm going to pass this off to Dr. Sai and Dr. Donahoe now to speak about lymphatic imaging. We recently wrote a review, Bringing to Light the Invisible, and the lymphatic system has been invisible too long. And these are our colleagues who really are bringing it to the forefront, allowing us to see the things we need to see so that we can intervene in the safest and most responsible way. Leo and Kevin, I'll let you guys take it from here.
Thank you, Dhruv. I'll start off. This is Leo Tai here. It's a pleasure to participate in this conference. And I just wanted to give a brief introduction to our department. So radiologists, we're physicians who help interpret imaging studies from a wide variety of different modalities. I think many people are familiar with X-rays, but radiology also includes CAT scans and MRIs, nuclear medicine, which Dr. Donahoe will get to in a second, mammography, and we're not limited to just physicians. If you have the next slide. But you'll see in a couple of slides, there's many sort of technologists, most which you as patients will actually interface with the most. So they're the ones who are putting you into the MR scanners and positioning you and making sure that you're comfortable. They're all part of our team, and it's a very large group. And so these are members of our lymphedema radiology team here. Marty Smith in the upper left corner is a body imager. He's one of my mentors and a guru when it comes to developing new protocols and pulse sequences. So we work closely together in trying to optimize the MRI images specifically to tailor to the needs of the lymphedema team. Kevin, who will speak shortly, is our nuclear medicine specialist. And then the two guys on the bottom are Jeff Weinstein and Manib Ahmed, are interventional radiologists. So they're at sort of the forefront for minimally invasive procedures and sort of diagnostic lymphangiograms. In the upper right, sorry, in the back of that same slide, we're expanding our team. So in July, Gunwon Kim, who was a resident in our program, is actually returning. She's a breast specialist who will also be focusing on lymphedema. So can I have yes, perfect. So one thing to know about radiology is not all pictures are created equally. And so I use MRI as an example, but you're going to hear it from sort of other radiologists as well. The way we acquire those images, we have to tailor those sequences or those protocols to the needs of our referrals, or to ourselves, to basically answer the question, right? So the question that we have that I get all the time for our team, there's many different questions that people need to know. It depends on whether it's coming from Kathy or from Dhruv or from Brett. You want to know everything from sort of how are the vessels working properly, for example, or simpler questions like where is the edema? Where is the worst of the edema? Where's the area that we really want to fix? If there's excess fat in the limb, where is that if Dhruv were to go in and do any of his debulking surgeries? Those are some of the questions. Once I understand what the questions are, I can sort of develop some of these protocols to answer them. So the pictures that you see on the screen here, they're from there are multiple different images that we acquire only to look at the kidneys. And so I just bring this up as an example. And I specialize in body imaging for abdomen and pelvis primarily, and we have over 80 to 90 different types of examinations that are tailored specifically to answer different questions, depending on the body part or the disease process. And that's sort of not any different in lymphedema. It's a different disease process that requires really specialized protocols. So, you know, an arm MRI is not created equal. And that's something that I think sort of well, speaks to the strength of our team, because every week, you know, occasionally I'll get a new question that I always want to sort of update our protocols to make sure that I can still sort of answer sort of the questions that will guide these therapies. And they constantly change as we learn more about the disease as a team. So can I have the next slide? So I'm going to pass this over to Dr. Donahoe, who's our nuclear medicine lead.
Okay, thank you very much, Leo. These images are nuclear medicine images. Some people think they're not as pretty as the CT or MR images, but I think they're gorgeous. What we're imaging here is not so much anatomy, is we're imaging function. And what we do is we inject a small amount of radioactive material that's labeled to a sugar molecule. We inject it in the skin, and in this patient on the left of the screen here, you can see we inject it in the feet, the tops of the feet. And the tracer we use, the sugar molecule that we use, is actually a lot less painful than the agent that a lot of other institutions used. We used to use sulfur colloid, but we found that it was not tolerated well by a lot of the patients. And after we inject it, we just watch it flow up the extremities and head to the node bed. On the left side of the screen there, you can see that there is one channel on one of the legs that goes up to a lymph node in the inguinal region by the hips. And then we also can do a technique called SPECT-CT. And you see that on the right side of the screen, where we take three-dimensional images of the distribution of this tracer in the body, and we fuse that with the CT images, and we can see where these spots actually are and which lymph nodes they correspond to. And it gives Dr. Singhal and the surgeons an idea of what to look out for. And also it tells us what part of the lymphatic anatomy is working and what part isn't. In the patient on the left side of the screen, you can see the right leg, the leg with the little dot by the hip, does have lymphatic flow up to the normal nodes in the inguinal area. But the other leg has all the tracer that's accumulating down at the bottom by the ankle and the lower leg. And it's not making it up to the lymphatics. And that's important information when we're considering further therapies to do. Thank you.
So these obviously prettier pictures are from an MRI scanner. These I want to give you some examples of some of the neat tricks that we could do with MR that complements the pictures that you saw from Dr. Donahoe. And so some of the questions that we are asked here, sort of that the MRI can help answer, is basically, where is the edema? And in patients who have chronic lymphedema, they can actually have fat hypertrophy, meaning sort of increased amount of fat in the affected limb. And Dr. Singhal often wants to know sort of where that fat is. So if you look at the images on the images on the top, there are the two legs from the same patient, and you can see all the sort of the bright rim on the limb where Dhruv is pointing at. That's what edema looks like on this particular MRI sequence. So we've designed this sequence specifically so that things that are bright basically are water-based, okay? And so that's what edema looks like on MRI, and that's when we try and highlight that. And you can appreciate that that leg is much bigger than the other leg. So this is a patient who has severe lymphedema of the left lower extremity, okay, the left leg. On the images on the right, this is acquired from the same patient, but the sequences, the images on the bottom, sorry, are acquired from the same patient, but we use a different set of pulse sequences now, where the bright things that you see there are made of fat, basically. So you can see that there's two in the middle part. There's these two bright dots, sort of in each leg. That's actually your bone marrow. inside your shin bone and sort of the bone behind it in your calves. They just happen to contain a lot of fat. So they show up right as well. But what's important for Dhruv is basically looking at the rim of fat on the outside. That's the fat that's just beneath your skin in your calves. And so you can see there's a lot more of that brightness and thickness of the affected limb. So that limb, in addition to having a lot of edema or fluid, also has a lot of extra fat. And that, knowing that is actually really important for Dhruv, because it will affect potentially sort of his surgical management, so which he can get into in a little bit. So, these are, we wouldn't have really thought of sort of putting these types of sequences in if we didn't know sort of at our conferences that these were the types of questions that were being asked. And often, in really, there's no other examination that we would do in MRI for the other body parts that would include this combination of images. It is really sort of tailored for the needs of the lymphedema patient. So next slide, please. So I know that I think Jeff and Munib aren't around here, but I can sort of, these are just some images from some of the interventions that some of our IR colleagues can actually do. So the image on the left is a X-ray image where they've injected a dye that you can see on X-rays. That's that black stuff that looks like kind of like a worm-like sort of projection. Those are what lymphatics look like under X-ray after you've injected some of that contrast agent into lymphatics. And you can see, one side looks a lot thicker than the other. And that's sort of, an example of sort of like obstructed, slow-flowing lymphatics. And the image on the right is a 3D reconstruction of the same patient, showing the dilated lymphatics sort of in that area. And so they can look for areas where there's a lot of narrowing that might be causing that obstruction. And in some cases, they may be able to go in there and put a stent in there, kind of analogous to sort of a cardiac stent, sort of to open up the arteries. They can actually sometimes do these interventions where they open up the lymphatics and improve the drainage that way. So hopefully you get a little bit of flavor in some of the images that we can take and some of the sort of the answers that we can provide to people like Dhruv and Brett to sort of to figure out sort of what to do next for the patients. This is just a website that tells a little bit more about what radiologists do. It's a great resource for patients, because I think often, like Dhruv says, we are sitting sort of in a room somewhere reading these studies, but we're very much sort of all over the place in terms of providing care to the patients. And I think often you see us through the technologists who really do take care of you while you're in here visiting and being scanned. And so it's always a pleasure for folks like Kevin and myself to be able to speak to you directly to showcase some of the things that we're able to do. So thank you very much for that opportunity.
I have a quick question, not to go off on a tangent, but why is it that, I live in Houston, which is a fairly big metropolis area, and it seems to me that this type of knowledge is only specific to certain individuals. I mean, is this type of knowledge like broadly distributed, or do you have to have specific training to interpret lymphatic radiology?
So that's a great question. So we aren't trained on this actually it's not part of our training in residency. We know sort of about the lymphatics, but the idea of lymphedema and sort of the imaging that goes with it is something that we learn from specialists in that field, and there are not that many of them there. So I learned a lot of it basically understanding what Dhruv and Brett do, and then designing things our protocols, as well as Kevin, sort of around sort of what are some of the questions that they're trying to answer. And in a span of the few years that we've started our program at the BI, we've learned a ton of really new things about sort of what these images actually tell us about our patients. And you know, and Dhruv can speak more to that, but we've published some papers on some of these new findings that nobody has really done this type of work in the past. So a lot of it is really exposure. A lot of it is a lot of, you know, I fully admit I knew nothing about lymphedema before
Gotcha.
Dhruv basically showed up one day and just said, hey, and I know Dhruv, actually I knew Dhruv as a resident many years ago, and then he just appeared one day, like arrived here at the BI as a new surgeon, and for the first 30 seconds I had no idea what he was talking about. And I think that's unfortunately the case with a lot of physicians, not just radiologists, but it basically requires that sort of, you got to get over that hill, and then you know, it takes a little bit of a learning curve. But you know, once we get into it, it's pretty. It makes a lot of sense. But again, you need the right team.
Perfect. Thank you so much.
Leo, Kevin, thanks for that. You know, and you know, to jump off your great question, Vern. You know, we call it the practice of medicine for a reason, and it's not that we're practicing on patients, but we are constantly learning. And seeing 900 patients in 3.5 years, there is so much each of us has learned. And as much as I kid Leo and Kevin as sitting in a room, dark rooms, reading images, frankly, they have become so critical to our team. They are often the ones who are really making the decisions for us about which pathway to take based on their really thoughtful interpretations of this very sophisticated radiology sequences. All right, so bringing it back to the map, the roadmap that we talked about, we're going to end off with lymphatic surgery. Again, part of the clinical triad, heavily supported by our radiology colleagues. So let's just talk about lymphatic surgery. I'm going to do this fairly quickly. I think we're moving along here with time. Is, you know, when a patient finally makes it to the lymphatic surgery clinic, honestly, a lot of the questions have been answered. A lot of the specialists that you've heard from tonight, we've already met, we've talked about the patients, and we've already figured out, are they fluid dominant or fat dominant? Not all lymphedema is the same. You actually need evaluations, radiographic imaging, as has already been discussed, in order to figure this all out. Essentially, the upshot is, if a patient is fat dominant, we're going to recommend a debulking procedure. We're going to go in and remove the fat. And then we're going to wait for that patient to stabilize. And then we're probably going to bring them back in 1 or 2 years and do one of these other procedures, a transplant or a bypass. But then you have patients come in, and time is not a consequence here. People could have had their disease for 4 years and not have any fat, and they're mainly fluid. And we don't really understand why. And if they're fluid, we're more likely to recommend a transplant or a bypass, depending on how their lymphatic architecture looks when we evaluate them. So I'm just going to briefly talk about 2 procedures, lymph node transplant. I'm going to talk about how I used to do it. I used to do it by taking lymph nodes from the groin or the neck and putting them in the leg or the wrist for upper or lower extremity lymphedema. I will just move on to share how we do, for example, upper extremity lymphedema treatment today for a lymph node transplant. Lower extremity is like the sister version of this. For the upper extremity, we go to the forearm, we make an incision, we find a main artery called a radial artery. We actually remove a piece of it, and what we do is we bring in this fat right here from the belly, which holds an average 6 lymph nodes, and we do various connections to the arm to make sure that it's alive when the case is done. This case will take anywhere between 5 to 10 hours, depending on what we're doing. This is what that fat I was showing in the other schematic looks like. It's about 12 by 3 centimeters. Dr. Sai actually comes into the room and puts on scrubs and a sterile equipment, comes in, brings in his very fancy ultrasound machine, and is actually able to tell us exactly where the lymph nodes are, and we count them. So when a patient comes out, and I'm going out after surgery to talk to the patient's family, I tell them, look, today we transplanted 6 lymph nodes or 8 lymph nodes. And we know we did it because we have the precision of Dr. Sai and his radiology team backing us up. This is what it looks like in the forearm. right before we close the skin. And this is what a typical patient will look like a few weeks right after surgery. The incision is fairly fresh, and it's going about a half or a third down the forearm. The most important concept to understand about transplant and bypass is this will improve symptoms. It will decrease your need for compression, not across the board, variably, but in a fair number of patients, you're going to have some increase in the decrease in compression, and it's going to decrease the risk of infection. The key concept to understand is that the way I describe it to patients is if I took a picture of you before and after surgery, you're not going to notice much of a difference. It's a very modest volume improvement. Kathy and her team will pick up on it using very sophisticated measuring devices we have, but it's not something the patient's going to wake up and say, wow. When they wake up from the next procedure I'm about to show you, they say, wow. And the next procedure is the debulking procedure. So this is offered for patients where we see a lot of fat. This is a patient, 43-year-old gentleman with left lower extremity lymphedema, actually following a pancreatic transplant. And this is a slide from Dr. Borson, a dear friend and colleague from Sweden, who has started a group a great amount, and showed in cadavers in the side that had lymphedema, you see all this extra fat compared to the other side. And so he came up with a technique for removing that fat. This is what a typical VAT looks like for us. These are procedures that I and Tilly will perform together in the operating room along with our resident team. And we will literally remove liters of fat out of an extremity that has had lymphedema. We use very sophisticated equipment that has been custom designed through really the art taught to us by Dr. Borson. And we brought it and designed it here in the US. And this is the result you can get, pre and post. And this is a year follow-up. I am not showing you our best result. This is our standard result after a debulking procedure for a patient with lymphedema. The key concept to understand here is while you get the wow effect, significant exchange in volume, reduction in volume, decreased risk of infection, improvement of symptoms, this requires 24/7 compression in order to maintain this over the life of a patient. So for a patient to say, look, that's an amazing result, I want it, no problem. You can have that result if you're fat dominant, and you can have that for the rest of your life, but you must wear compression 24/7. And that is a mantra taught by Dr. Borson. I'm going to say a couple of lines about preventing lymphedema. It's not what I want to focus on. If lymphedema is a progressive disease, which we know it is, why not try to prevent it? And if we know the #1 cause of lymphedema is removal of lymph nodes, for example, in the case of breast cancer, lymph nodes in the armpit are removed, why not find the arm lymphatics and reroute them into a vein or do a lymphovenous bypass and prevent that train or the lymphatics from ever coming off the track? And this was described by Picardo Campisi in 2009. Our group and their rate of lymphedema over 4 years was 4% compared to historical controls of about 26%. We recently looked at our results at the Beth Israel, and all I'll share with you is and this was just accepted for peer review publication in the main journal in our field, and we had one patient giving us a rate of 3% doing this procedure with 1 year follow-up. So we think this could be a potential game changer to try to prevent future patients from developing lymphedema. I'm going to end with, there was a big win recently in the state of Massachusetts, and this is really a big deal, in my humble opinion. Our team, our research team, led by Anna Rose Johnson, before Melissa came on, Melissa took Anna Rose's position, is going to do amazing things, already is this year. Anna Rose and I worked hard on this policy. It was approved by the largest third-party payer outside of Medicare and Medicaid. And this is a policy covering the surgical management of lymphedema. Everything except for prevention. Lymph node transplant, lymphovenous bypass, and debulking are now covered in the state of Massachusetts through PCBS MA. And this is policy number 037. You can Google it. It's all public. Take it to your insurance companies and show them what's happening elsewhere in the world. Finally,
Can you move to Texas?
yeah, but you know what? I will tell you, you have leaders in Texas that have worked. They are looking and they are fighting hard to make this happen in the state of Texas. So you just wait, it's coming. And the last slide is, we do have our annual symposium. We invite you all to it. Check it out at harvardlymphaticsurgery.org. It is postponed. It was scheduled for November 2020. We have made the decision to postpone it. It will be November 2021. Dates and times, locations to follow. If you just check out the site, probably the next month or two, we'll have all the details up. So everyone be safe on behalf of our center. Thanks for having us. And we'd love to open it up for questions. We're all going to be present. So our specialties will take it. And I'll moderate to who in the center will answer it. Thanks, Aaron.
Okay, I had a question submitted from someone before the Q&A started. Let me just pull it up.
I'm going to let everyone look at this one while we do the Q&A.
Yeah, go ahead. Go ahead. This one's fairly long. Go ahead.
Oh, no. I was just going to leave this slide up for people to look at while we talk.
Okay. So I see I'm in the question and answer forum. It says, what surgery are you speaking of, cancer or lymphedema surgery? And Kathy said she'd like to answer this question.
I think that question came up when I was speaking, and I think I was initially speaking of pre and post-operative care, and we were referring to the liposuction and the debulking procedure, and also the lymph node transplant and the lymphovenous bypass. So I was talking about surgery specifically for treatment of lymphedema.
Yeah, and I'll just back that up by saying, you know, what's become critical is surgery doesn't occur in a vacuum. Surgery occurs as a team. And so what we do in the operating room is just the beginning. There is so much that happens after it. And frankly, I would say what we do in the operating room, depending on the procedure, is sometimes only 5 to 10% of the entire story. And so the therapy that backs it up is so critical to the long-term outcomes. So the work by Kathy and her team on the outpatient side and Tegan and her team on the inpatient side are critical.
The next question is, do you ever consider lymphedema from scar tissue due to abdominal surgery like a cholecystectomy or multiple cesarean section?
Great question. I will take, Brett, do you want to answer that?
Sure, I think that's a good question. We get asked that frequently. You know, is there an actual pathway that's disrupted with a superficial scar? And I think, you know, the answer is maybe. Often when we see a patient, if clinically they look like they have lymphedema, and then we may send them, if we're not sure, for a lymphoscintigram with Dr. Donahoe. And if it looks like they have lymphatic dysfunction and we have no other possible cause, we say, okay, maybe it was the surgery. And if the timing fits with when you had a C-section or when you had a cholecystectomy, maybe. I think there's an overlap in terms of when patients develop lymphedema. It may be that you're living with, you know, suboptimal lymphatics and they're holding on and they're doing fine, and then you have a second hit. You know, not traditionally do I think of a C-section or cholecystectomy. More often it's a venous ablation or some trauma to the limb specifically. So and I think the team is very hesitant to say a definite yes or no, but often things may be a contributor on top of some underlying lymphatic dysfunction. So I think, again, the answer is maybe, and we really try to delve into the specifics of a patient's circumstances.
Awesome. Thanks, Brett. I see some questions here, Vern. Do you mind if because I kind of see where they might go, can I jump on?
Yeah, take it away.
Great. I'm picking these to get different members of the center to answer while we have their expertise here. There's a question here. I'd love to know what the difference is between lymphoscintigraphy and ICG. Kevin or Leo, do you mind taking that one?
Lymphoscintigraphy is a specific nuclear medicine technique where we inject a small amount, as I mentioned, the sugar. It's labeled with a small amount of radioactive isotope. And the scintigraphy part of it refers to the little flashes of light that we pick up with our instruments called gamma cameras. ICG is a technique that Dr. Singhal does. Often in the operating room, and since he's the specialist in that, I will let him talk about that.
Yeah, so with the indocyanine green lymphography, what we're doing is we're just injecting a dye that's near infrared. It's like X-ray vision. So we inject it into the skin, which is a super highway for the lymphatic system, and literally shoots up the arm in seconds. In a normal scenario, and we use a camera and just hover it over the skin, and we can actually see the lymphatic channel. In a disease state, we're not going to see a channel, but we're going to see different kinds of patterns, and we use those patterns to grade the severity of the lymphedema. So ICG kind of gives you a little more of a snapshot. Lymphoscintigraphy gives you more of a functional, big picture view.
And one of the issues with ICG is you can't see very deep lymphatic channels as well with ICG as you can with the lymphoscintigraphy. The radiotracer that we inject penetrates through the skin, and no matter how deep it is in the limb, and it's a little tougher for ICG to see the deeper channels. And with our pictures, as I showed you earlier, we can get a picture of the entire extremity at one time and look at the lymphatic flow up the whole extremity.
Thanks, Kevin. We have a nice question here. Can you address prevention of breast cancer-related lymphedema? Kathy, this is going to be a question for you. CLT here and C post-surgical patients. What are your team's recommendations or protocols?
So we do surveillance preoperatively. I think that's one of the most important steps, is so we know what the patient's baseline is, because quite often we might expect both limbs to be equal in size, but we find out preoperatively we've seen even 8-9% difference in limb volume before we even start. And if that's the non-operative side, we want to make sure we know what their baseline is. And then following them at intervals post-surgical. And I don't know that we have the ideal interval, but we do it 4 to 6 weeks, 3 months, 6 months, 9 months, 12 months. But following them at intervals so that we could pick up any changes early enough that we could start treatment. And I think that's key. Just making sure. We had an email from one of the oncologists just last week wanting to know, do we even see people with lymphedema anymore? It's been so long since I've seen somebody with lymphedema, and I think one of the reasons she's not seeing as many patients with lymphedema is because we're doing the preventative surgeries, but we're also monitoring patients and picking them up early and treating them at a sub-threshold level. So our center uses a diagnostic criteria as patient having symptoms and one objective measure of lymphedema. And that could be an increase in the bioimpedance, the LDEX score, or it could be an increase in volume of 10%. But if somebody has an increase of volume of only 5%, it doesn't mean we're just going to keep monitoring them. We might intervene at that point and start either doing some MLD or some exercise, or maybe even add compression so they don't progress to the 10%. So early intervention is also key.
Awesome. Thanks, Kathy. We have another question here that I'm going to ask Sarah to help answer for us. Is there a benefit of doing transfer after doing the debulking procedure?
Can you hear me?
Yes, we can.
Perfect. So I think we find now we kind of switched this protocol. Oh gosh, I don't know, probably a year or two into our program. And, you know, we actually did a couple patients where we did lymph node transplant first. And when we review the imaging at conference, we're reviewing the MRI, we're looking at edema, you know, fluid or fat. And we've now found that patients that are more fat dominant, we're going to do a debulking procedure. And we're going to really hone in on that fat that's causing the size of the extremity. And we're going to shrink that extremity down as much as we can. And then we're going to transfer over to the lymph node transplant, which is going to take toll on some of that edema or that fluid. So we really recommend kind of doing that new protocol that we have, which is going debulking to the lymph node transplant.
Perfect. Yeah, I agree. That was a really nice question, really nice answer, Sarah. I mean, this is a protocol I know Jake Ranzow does in California, and we believe in as well. I mean, I remember like Ranzow and I talked about this in 2017 in Barcelona. He'd been doing it for a while, and I was like, yeah, you're right. I mean, this makes perfect sense. You know, you go in, remove the fat, improve the soil, and then you come in and you do a transplant. So usually that's 1 or 2 years after the debulking. Thanks, Sarah. Nice question as well. I'm going to ask Tilly to take this next question. Tilly, we have a question. How many times can you have each surgery?
Thanks, Dhruv. Everyone can hear me?
Yep.
Yep. Hi. So this is an important question, and one that I think being part of a multidisciplinary team takes a big play. You know, ultimately, we'd like each procedure to only be done once on a patient, right? So actually, before surgery, we're pretty careful to be sure that patients are very compliant with care, because if you're not compliant with therapy, actually one procedure that we perform on you may not give you the results that you want. So once we know that patients are compliant with care, we will usually proceed with the debulking procedure, knowing that compression is very important after this procedure, because without compression, you might actually need to repeat this procedure if, you know, swelling and fibrosis were to return. So usually one time for debulking procedures. As far as LNT, also typically a procedure that you would only have done one time, especially because we have to go and harvest lymph nodes from another part of your body, which is a pretty significant surgery. And as far as treating chronic patients, the third way with LV bypass, that is a procedure that can be repeated. And that's really the only one that we would typically see being done more than one time per patient.
Perfect. Thanks, Tilly. Great answer. I have a few questions here. I'll ask Leo, do you mind taking this one? Who peer reviews the work you publish? I ask as there are not many others with relationships you have in your multidisciplinary approach, specifically imaging and surgical doctors.
Yeah, that's a great question. There is a small community of imagers that have specialized in the field of lymphedema, those are the people who end up reviewing our articles. And so it is a growing community. It's a slowly growing community, but it is in there and it is established. I think what's interesting is that sort of a lot of the newer advances in imaging, like MR, like the things that I just spoke about, those have come into play more recently because it's only mattered sort of more recently because the surgical options that are available weren't available, 10, 15 years ago. So lymphoscintigraphy is a technique that's been around for actually decades. And it's been used for sort of looking at other disease processes. But yeah, so the MR techniques sort of, often what we do is we adapt some of these techniques that are used for other disease processes and apply them to newer ones. And so that's what we did here with lymphedema. And so there is a community that's been sort of, that's always trying to advance some of these pulse sequences, definitely within the MR community, but sort of in all different modalities as well. And so those are a lot of the people that end up sort of peer reviewing So it's usually a mixture of scientists as well as clinicians specializing in the field. Lymphedema is interesting because a lot of times it has to do with the extremities. So sometimes, sort of in the radiology field, it's MRI specialists. It specializes it's specialists also in musculoskeletal imaging, because those are the people who tend to see them, and it also depends on the modality. So hopefully that answers your question.
Great, Leo. Thank you. Vern, you let me know about time. I mean, we're here. We're all yours. I see you just let us know. You let us know when we're cut off.
Yeah, I know I'm cognizant of the time, and it's been an hour and a half, and I think we'll just do this one more question. Offline, I got a question about an acupuncture study. Was it Anna Rose that did that on your team?
Yeah, so we actually have an acupuncture study going right now where we are enrolling patients who have breast cancer related lymphedema and doing a acupuncture protocol put together by a PhD in oncology acupuncture from the Dana-Farber Institute, who we've been collaborating with. And it's an exciting study. We only have a few spots left. It's about to close, but we're looking forward to showing our results in the near future. If you don't mind, just a couple more questions. Can I try to answer?
That's it. Yeah. Go ahead.
Or do you wanna do a firm stop? I'm okay.
No, I'm at your, whatever. I'm completely flexible. We can stay all night as long as you don't tire us.
We'll do 3 more questions because I think with 3 more questions we'll have this set. Except the questions keep coming.
I feel bad for the technical delays that we had in the beginning.
No. Listen, it's our honor to be here. I'm going to send this question to Sarah. Sarah, we have a question. What added benefit will you get from doing lymph node transfer if you had successful debulking surgery and work compression 24/7?
You can hear me, right?
Yep.
Okay, perfect. So in regards to this question, someone that has successful debulking surgery, well, first off, they're having debulking surgery because they have that fat hypertrophy that's present. We want to get that extremity down as much as we can. They've been in compression 24/7. They may present into our office where we ask a significant amount of questions related to symptoms of the extremity. So heaviness, tightness, swelling, history of infections, those sorts of things. And we take those into consideration when we are deciding on the surgical approach. But someone that's compliant 24/7 in compression, it could be a year time after surgery, it could be 2 years time. And then going into talk about a lymph node transfer, that surgery is going to kind of really reel in on those symptoms of infections, maybe some tightness as well. Because when you come back post-operatively, we're going to ask you those same questions. We're going to ask you at 3 months, 6 months, 9 months, 12 months. We're going to ask you, have these improved? A lot of patients will come back. They'll say, yes, some of these symptoms have improved. But then once they get into that lymph node transfer, they come back and some of those symptoms of tightness, even heaviness, those things will have improved even significantly more. And like we said earlier, the lymph node transfer is really related more to the edema and the flow of the lymphatic system. So that's what we're kind of leaning towards once we hit that time frame with a patient.
Beautiful, thanks. There were questions here. I don't want to ignore them. I was just saving them because there are probably more questions for me. One question was a lymph vessel transfer. So a lymph vessel transfer is really where you're taking lymphatic channels and transferring them with an artery and vein and making kind of like a free tissue transfer. For me, I don't perform lymph vessel transfer. My mentors really taught me lymph node transplant, which I like because if you bring in lymph nodes, we know in animal models that as long as that lymph node's alive, it's going to create a lot of channels coming out. And so for me, the logical thing to do is to do a lymph node transfer over a lymph vessel transfer. Though I know there are legends in our field, Dr. Koshima in Japan and others who advocate for this. But in my hands and in our team's experience, we would go with a lymph node transplant. Another question, history of cellulitis infection. Do we see a reduction? Absolutely, Dr. Borison, it's not a cure. It's not like you get 0 infections, but you see a reduction. Dr. Borison shows an 83% reduction in infections after debulking. Anecdotally, I will tell you, we have found lymph node transplant, which actually brings in an immune function into the extremity, a fresh, healthy immune function, as helping to reduce the incidence of infection. With that, Vern, do you want us to take it there, and any other questions we'll answer offline?
Oops, let me get off mute. Yep, any other questions, we'll follow up. I think this is an amazing, I think you hang the moon, you and your team. This is absolutely amazing, it's phenomenal. You know, in light of the patient symposium being canceled due to, you know, a global pandemic, which is outside of everyone's control, you know, we teamed up and we decided to give patients some hope and things to look forward to. You know, the research, the science, the work doesn't stop. We're going to keep moving forward and look for that silver lining for everyone in the future. And I'll just let you close, and then we'll shut down.
Okay, you know, like you spoke at in Boston, it's the century of hope. This is a new horizon. Look at the slide you're looking at. We've got third-party payers to give coverage. You got brilliant people like my colleagues on this line sharing their experience from all levels, the MD level, nursing level. We are attacking this from all perspectives. And it's not just our center, there are other centers around the country and the world that are doing fantastic things. And so, you know, Vern, it is the century of hope. And this decade's starting off a little rough, but we're gonna get back going soon enough, and it's gonna be an awesome decade. And our team's gonna be there for the patients. And thank you for having us. And everyone be safe. And we'll see you soon.
Thank you. Thank you, Dr. Singhal. And thank you to the rest of the team at BIDMC Lymphatic Center. Have a good evening and God bless you.
Good night.
Good night.